since too many years and too many decades, but we are speaking now about the recent form of this operation that we reach very, very deep near to descending membrane. That's why we call it DALK or deep anterior lamella keratoplasty. The indications of DALK are any corneal pathology with normally functioning endothelium. The most common indications are keratoconus and post-LASIK ectasia and other ectatic conditions of the cornea, superficial and stromal opacities and dystrophies of the cornea. Of course, the advantages of DALK over penetrating keratoplasty are great. There is no endothelial graft rejection, no graft failure. It is an extraocular procedure, short-term use of topical steroids, and the biomechanical properties of the globe is much stronger than in PKB. And there is another important advantage of DALK over PKB, that it expands the pool of potential cornea donors. We can utilize lower quality donor corneas, and we can use one donor graft for 2 transplants, DALK and DMEC. So this is the concept of corneal splitting. We split the cornea into 2 grafts, stroma and epithelium doing DALK, and endothelium and descending membrane doing DMEC. And this, we can use the DMEC graft the same time, or we can transfer it to another hospital or to another day in an ice box. This shows that the smooth learning curve, because whenever you have any problem with DALK, you can convert easily to penetrating keratoplasty. So we always say that DALK, it is a tough learning curve, but it is not that dangerous, because anytime you can convert to doing penetrating keratoplasty. This advantage of DALK, it is sometimes technical difficulties, longer surgery time. But as I always say, the DALK operation has known to have a tough learning curve. However, in the next 45 minutes, I hope that I can share with you lots of tips and tricks, which in my opinion, will help you achieving the perfect big bubble DALK. We have 3 ways of obtaining the DALK, either using injection of saline in the stroma and making lamellar dissection, or using a visco dissection, or the way I am doing is using air for dissection, and what we call it the big bubble DALK. My talk will be concentrated on the last type, which is the big bubble DALK. These are the steps of big bubble DALK: centration, the terrafination, and then partial thickness terrafination, and then big bubble formation by injecting air in the stroma, stromal dissection to debulk the cornea, and then doing the brave slash to open the space of the big bubble, and then cutting the remaining stromal flaps by right and left corneal scissors, and then preparing and stripping the donor descending membrane before transplantation, and finally suturing, either using interrupted or continuous suture. Of course, the most important step in these steps is the big bubble formation, which is a key step in the operation. The secret of success in obtaining the big bubble is to inject air very deep in the stroma. So injecting air gradually, air will, at a certain point, it will have pressure to detach descending membrane and making the big bubble in the anterior chamber. So we have a lot of tips during the operation. I have divided these tips into 4 groups. The first group is how to get the big bubble consistently. This is a very important, that in almost 90% of cases or more, you should have the big bubble consistently in almost every case. The second group of tips is how to differentiate between type 1 and type 2 big bubbles. And the third tip is how to diagnose some tricky situations, like, for example, collapsing big bubble and premature opening of the big bubble roof. The fourth group of tips is how to open safely the big bubble roof. So I will speak about all these tips during my demonstration of every step in the operation. The step number 1 is marking the corneal center. So I usually make a fixed distance by a caliper. I'm making 4 different marks from the limbus and making my center inside this box. So as you see, it is perfectly centered. But be careful. Sometimes if you are not meticulous in deciding or detecting your corneal center, you may be having an eccentric terifynation like this situation. So you have to spend some time and some minutes for perfect centration of the corneal terifynation. The second step is terifyne adjustment. You have to know your terifyne. You have to know that each terifyne suction, I'm using usually the suction terifyne. You have to know that moving the refined blade clockwise, each quarter turn will cut through the cornea by 60 microns. And you have to know what we mean by the 0 position in which the terifyne starts to cut if you put it over the cornea. The 0 position is when the terifyne blade is aligned with the vacuum chamber. So this schematic drawing of the suction terifyne. This is the outer tube. This is the inner tube, what we call it the vacuum chamber. And the red is the terifyne, the sharp terifyne. So when you have the sharp terifyne aligned with the vacuum chamber, we call this the 0 level, in which if you put this terifyne on the cornea like this, when you start rotating, it will start cutting immediately. If the blade is withdrawn upwards and due to anti-clockwise rotation, and with clockwise rotation, the blade will start cutting through the cornea. So as I always say, spend a few minutes for terifyne adjustment. Under the microscope, I am pointing to the terifyne blade, and then I'm trying to have my terifyne blade exactly aligned with the vacuum chamber. This is what we call the 0 mark. But we don't like to put the terifyne in this position over the eye. We have to withdraw the terifyne for 3/4 turns to have a good grip and a good vacuum over the patient's cornea. So make the terifyne at 0 position and then withdraw upwards or anti-clockwise for 3/4 turns. So we come to the third step, which is partial thickness terifynation. As we know, we are doing lamellar keratoplasty. We don't penetrate into the anterior chamber. So we want to do a partial thickness terifynation. How many quarter turns I am supposed to do? This is the first secret in my presentation of how to get the big bubble consistently. It is not a standard depth of terifynation. It is variable from case to case. So you have to make your partial thickness terifynation tailored according to your patient's corneal thickness. So this is how I do the job. This is the cornea, and this is the site of terifynation. For example, 8 millimeter. I take pachymetry, and then I will take the thinnest pachymetry as a safety margin. Another safety margin, I take 80% of this thinnest pachymetry, and then I divide this 80% by 60 macron to get how many quarter turns I am supposed to do in this special case. I want to emphasize that what is important is the thickness at site of terifynation, not the thickness in the center anymore. What's important for me is the thickness at site of terifynation. So I go to the pentacam map before the operation. I go to the 8 millimeter circle. I choose the thinnest pachymetry, and then I will do my calculation. For example, if I have the thinnest pachymetry is 540, I will take 80% of this and I will leave 20% as safety margin. So I will be cutting 432 macron. I will divide this number by 60. This will give me the number of terifyne turns I am supposed to do in this particular patient. So this is very important to have very deep terrification. This applies, what I have mentioned now applies for some terrifines and do not applies to others. For example, in my country, I am using Katina and JED-MED terrifines. These calculations are perfect with these terrifines. But some countries have what we call coronet. This coronet needs special calculations. So what I have mentioned is not applicable to any suction terrifying. So of course, I have no interest in all of these devices. There is another way of doing partial thickness terrification. If you are fortunate and having the Moria adjustable terrifying, this is the blade and adjustable ring, you can make preset adjustment of the blade. As you see now, you go and there is a ring, you make your terrifying adjusted, for example, in this case, at 400 micron depth. And you go, you cut, you don't count how many turns. It is a preset calculation. And as you see, it is very deep terrification, and you will go doing the operation and getting the big bubble according to your calculation. So you have to know very well your terrifying, and you have to know how to use it to make a very deep terrification according to the patient's corneal thickness at site of terrification. So after making your calculation, you go to the patient and you start rotating the terrifying, and you will see now that the terrification is very deep. You see, it is very deep terrification, and this is a very important step in doing big bubble DALK. So as I always say, not only the PEM2 laser can reach this deep level, but a simple manual technique can do so. My advice is go to up to 85% or 80% of the corneal thickness, again, at site of terrification. We come now to the fourth step of the operation, which is the major step, the big bubble. As I always say, the big bubble formation is a key step in the operation. So you have to study this bubble very carefully, as I will show to you now. Originally, we are using the needle to inject air. If you are using the needle, you will be superficial because you want to be safe. You don't want to injure this membrane, but the chance of success is very low because you are injecting very superficial away from your target. But if you are using the needle and injecting very deep, it is dangerous. You may injure this membrane, but the chances of success are very high because you are injecting very deep. So to solve this problem, we have to use a blunt cannula, not the needle anymore, and we have to put this blunt cannula as deep as we can. As I have mentioned before, I am doing deep terrification to put the cannula in the deepest part of this groove. So the secret of success is deep placement of the cannula. We have in the market a lot of cannulas. We have Donald Tang cannula, we have Sir Nicola's cannula, we have Rajesh Fogla's cannula, we have Fontana's cannulas. All these cannulas have blunt tip, all have 27 gauge, and all have the pour down. But for myself, 15 years ago, I have started using Donald Tang cannula, and I found it very useful. But of course, the other cannulas are great, and you can use whatever cannula you have in hand. It should be blunt cannula. So we have done a very deep groove, but we need to place the injecting cannula deep as well. It doesn't make sense that we did a deep groove and then to inject superficially. It will be nonsense that we are doing a deep groove and then we are afraid to inject deep and to inject low. So we have to inject very deep. I will show you my technique of injecting the air very deep using a blunt cannula. First of all, we define the deepest part of the groove by making a minimal dissection by crescent knife, just a mark of the deepest part of the groove. Then we start doing the tunnel by making a small nick in the deepest part of the groove by sharp insulin needle, just the first ½ millimeter. And then we go by a blunt spatula, 27 gauge spatula, in the deepest stroma and making our tunnel in the deepest stroma And then finally, we go with the blunt cannula mounted in a 5 cc syringe, very deep in the stroma, and we inject air very deep. And if you are following these steps, you will be having the big bubble immediately from the first injection. Again, I will show you my technique. You open the groove widely. We define the deepest part of the groove. Then we start our tunnel by sharp insulin needle, the only 0.5 millimeter. And then we go by a blunt spatula, very deep. We are not afraid of damaging descent membrane because we are using blunt instrument. And then we go with the blunt cannula, attach it to 5 cc syringe, and then injecting, and you will be having the big bubble immediately in the straightforward case as you see. It is always a reproducible technique. So to revise again what I have mentioned as regard getting the big bubble consistently, look carefully at the pentacam map, choose the thinnest corneal thickness at site of terrifination. You have to know how to adjust terrifying at 0 mark. You should make a very deep terrifination. You should inject air very deep as well. And of course, you should use the blunt cannula and not the needle anymore. These few tips are very informative and very valuable if you are doing big bubble tap. So as you see, it is always a reproducible technique if you follow these tips, especially in the straightforward keratoconus patients. Moreover, the aim changed, not only getting the big bubble from first injection, but immediate bubble formation without even any stromal emphysema. As you know, we always inject air in the deep stroma. We usually have some stromal emphysema, some whitening, and then after this whitening, we start having the big bubble. But if you are injecting very deep, very near to your descent membrane, you may have the bubble immediately without any stromal emphysema because there is no time for this because you are injecting few microns away from descent membrane. Look to these 4 examples. You look, the bubble forms immediately, no emphysema. Again, second example, the third example, you inject and you'll be getting the bubble immediately without any stromal emphysema. Of course, our aim is not to have these transparent big bubbles, but this shows and supports my theory of the importance of injecting very deep, whether you have the big bubble white and opaque or whether you have it transparent, doesn't make any difference. But these 4 videos support my point of view that deep injection have a great chance to get the big bubble. A good sign and tip, while introducing your spatula in the deep groove, you may feel it gives away in front of you because this means that you have reached a deep plane. As you know, the deep stroma is not as compact as the anterior stroma. So since you entered the deep stroma plane, you will find your spatula giving way, and this is a good sign that you will be injecting in the correct plane. Watch carefully this video. You see some resistance, and then suddenly the cannula jumps in front of you. This means that you are in a good deep plane, and when you inject, you will be having bubble immediately. Another example, you see some resistance, and then suddenly it gives away. This is a good sign that you are in the proper plane, and you will be getting the bubble immediately, even without any stromal emphysema, as you see. So, what are the signs of big bubble formation? We have 3 important signs. The first sign, you should have a circular, well-defined edge. If compared with the intrastromal emphysema, it is white and feathery, but the big bubble has a very well-defined edge. The second very important sign is you should have rise of intraocular pressure. The globe becomes firm and hard immediately after getting the big bubble. If you have just stromal emphysema, you will find that the pressure is still low. And well-known, the famous small bubble test. So this is what I mean by the well-defined edge. And this the idea of the small bubble test. If you have the big bubble in the middle, and if you inject a bubble in the anterior chamber, this bubble will be seen in a kidney-shaped configuration in the periphery of the anterior chamber because the center is occupied by the big bubble. So we call this the positive small bubble test. So this example of a small bubble test, you see the small bubble is trapped in the periphery of the anterior chamber. Another example. Of course, you may need this test in the beginning, but if you are experienced enough, you can recognize that you have the big bubble without any need to make the small bubble test. Another example of the small bubble test, injecting air in the periphery of the anterior chamber, you will find the bubble is displaced in a kidney-shaped configuration in the periphery of the anterior chamber. Another important tip is sometimes you may have resistance of enlargement. You see, when you are injecting air, you have some resistance. You see, it doesn't want to enlarge. You can wait and inject more and more and more, and until at a certain pressure, it will bob up and the bubble will have its final size. Another example, this example I have learned from my dear friend Rajesh Fogla, that I can stop at this time because there is resistance. I can do paracentesis, and this will lower the pressure behind the bubble. And if I go to inject again, it will allow the bubble to enlarge and to have its full size. So if you have any resistance during injection, just stop injecting, making paracentesis. This will lower the tension behind the bubble, and inject air again. You will be having your full size of your big bubble. The big bubble, it may form from single injection, or may form from 2 injections, 3 injections, 5 injections. You have to be consistent and stubborn to have the bubble in every case. So this is an example of getting the big bubble from the first injection, as I have shown before. And this is example of having from second injection. You see, these are emphysema, not big bubble, because I was using the needle all days. But with the second injection, you will find the well-defined edge. You see this well-defined edge? So you have the bubble from second injection. Sometimes you may need to inject too many injections. This example showing injection for the first time, you see just emphysema, no well-defined edge, and the tension is still soft. Injecting again, the same site, again, no more than emphysema, tension is soft. Choosing another deeper plane, injecting again, only whitening, no big bubble. So making lamellar dissection, going deeper in a fourth plane, and watch carefully. We will be having the bubble now with the fourth injection. You see, you have the big bubble now. The globe become firm. So as I always say, you have to be patient and determined until you get the big bubble. But what if the big bubble formation is impossible, either due to intraoperative complications or as a preoperative decision in some special cases in which we decide not to inject air, like keratoconus with previous hydrops, or trauma cases with deep scars involving the DM. So in these situations, we have to learn the manual DALK technique. This needs another special lecture alone, but I will show you my own technique, what I call the spiral technique, in which I have got most of it from my friend also Rajesh. We start doing dissection by a small venous scissor with blunt tip in the periphery in a spiral way. And while you are doing this, you will find yourself getting into a deeper plane. You are making now the second turn. You will be having a deeper plane until you will find yourself, you can peel off the stroma, as you will see now. Since you are in a deep plane, the stroma has a minimal attachment to the posterior layers, and you can start now doing, as you will see now, you see I'm doing peeling off. This peeling off couldn't be possible if I'm superficial. So you have to be very deep so that you can peel off the stroma and to be in a very deep plane, as you see. Sometimes we may need some sharp dissection, like using a crescent knife to continue this peeling technique. So you have to put your manual dissection technique in your pocket in the case you don't have the big bubble. The third group of tips is how to diagnose some tricky situations. I call it the collapsing big bubble. and the unintentional opening of big bubble roof. I will show you now the collapsing big bubble. What I mean is sometimes when you inject air, like this example, when you are going out, the air is coming out. Again, I will do it in slow motion. You see, injecting air, getting the big bubble, very well-defined edge, and then the air escapes while you are going out. So the walls of the big bubble have been collapsed. No air inside anyway. So the proof is when you go to do small bubble test, it is negative. It's supposed to be positive because we have a big bubble, but the bubble have escaped. I call this tricky situation the collapsing big bubble. Another example, you see injecting, having big bubble, and when you are going out, you see the air is coming out with you. And when you do the small bubble test, you will be astonished. It is negative because the bubble have been collapsed, you see? But the bubble is there. If you go again and inject air, you will find bubble is present, but hidden or collapsed. If you inject air again, you will find it. The only solution for this situation is to inject viscoelastic in the bubble space, because the viscoelastic has no tendency to escape through this leaking track. Another example of big collapsing big bubble, you see, when you inject and when you come out, the air collapses with you. So we do a small bubble test, it will be negative. It should be positive, but the bubble have been collapsed. When you go again and injecting air, you will find bubble is here. You see, the bubble have formed. You see, this is a big bubble, and these are the small bubbles in the periphery of the anterior chamber. So this kind of bubbles, I call it the collapsing big bubble. Another example, you see, when you inject, you will be having air coming out while you are taking out your cannula. And this is the cause for this tricky situation. We have a leaking track, as you see. So why it is crucial to recognize such situation? Because in the ordinary cases, we go and make opening of the big bubble roof, as we will see now later in my lecture. So if you have this bubble collapsed and you don't recognize such tricky situation and you open the roof, you will be opening the roof and descent membrane at the same time. So it is very crucial to diagnose this tricky situation. I will come now to the very important topic, which is the different types of big bubbles. And I think this article presented by Professor Hermander Dua have made a great, have made a revolution in our understanding of the mechanics of the big bubble. So this layer just in front of the descent membrane, we either call it Dua's layer or we either call it the predesmatic layer. It is the last layer in the deep stroma. So according to this predesmatic or Dua's layer, we have three types of big bubbles. Big bubble type 1 with characteristic white edge, and big bubble type 2 with characteristic clear edge, and mixed big bubble in which we have type 1 and type 2 in the same patient. So I will show you the difference between these different types of big bubbles. Type 1 big bubble, it usually starts from the peripheral center, as you see. Why? Because there is strong attachment of Dua layer at the periphery of the cornea. And the maximum diameter of this bubble is 8.5 millimeter due to the strong attachment of the Dua layer to the stroma. And as you see, the plane of separation is between the stroma in front and Dua's layer behind. And as I have mentioned, this bubble is characterized by having this white edge. What's important for me is the edge, the white edge. Removing the stroma will be having the floor formed of three layers, Dua's, descent membrane, endothelium. And of course, as we know, the Dua's layer is characterized by this rough surface. As you see, this rough surface is highly characteristic of Dua layer. Another example, white edge, again, rough surface of Dua's layer. A third example, characteristic white edge, as you see, and characteristic rough surface. Of course, when you want to decide the surface is rough or smooth, you have to have it dry. because any wet surface looks very smooth. So you have to dry the floor, and then you judge whether it's smooth or rough. These are another examples of big bubble type 1 with its characteristic white edge. If you come to big bubble type 2, or we sometimes call it the pre-prismatic big bubble, it's completely different from the first one. It usually starts from a peripheral center, as you see. Why? Because in the dual layer in the periphery, there is fenestration. So when you inject air, some air may escape from these fenestrations in the periphery and make type 2 big bubble, as you see in this animation. So again, it usually starts from the periphery to the center, and it has diameter of may reach up to 10.5 millimeter, very large bubble. And as you see, the plane of separation is between the Dewey's layer in front and the descent membrane behind. It has characteristic clear edge. As you see the edge is clear. Sometimes we call it the glassy big bubble. And if you remove the stroma, you will be having the Dewey's layer with it, and you will be having the floor formed only of descent membrane and endothelium only. And of course, descent membrane is very smooth or featureless. Again, type 2 big bubble has characteristic clear edge, the glassy big bubble, as you see, and it has a very smooth surface when you remove all layers of stroma. Another example, you see this glassy edge, and again, you will be having this very smooth surface. These another 3 examples of big bubble type 2 with its characteristic clear edge. We come to the complicated types of big bubble, the mixed big bubble. We have 2 types of mixed big bubbles. Either we have complete big bubble type 1 in the center, and another partial big bubble type 2 in the periphery. This is the first category. The second category, which is a very rare category, is do you have 2 complete big bubbles behind each other. The central one is complete big bubble type 1, and another complete big bubble type 2 behind it. This is a very rare occasion. I have encountered only twice in my 15 years journey with DALK. So these are the mixed big bubble, the complete type 1 and the partial type 2, as you see. These are the big bubble type 2 after you open big bubble type 1. Again, example, you see injecting air, nothing is clear whether you have type 1 or 2, and then opening type 1, you will be having another big bubble type 2. You see, this is a big bubble type 2. Of course, we advise you just to puncture it, to decrease its space, as I have done in this. If it is small, you can leave it. But if it is large, I prefer to just puncture it to release the air inside. This is a very rare example of having 2 complete big bubbles behind each other. Watch carefully when injecting. This white edge is big bubble type 1, as I have mentioned. But watch carefully at what will happen now. So this will big bubble type 1, as you see. And there's another edge here. You see this edge? This type 2 big bubble. So I am pointing to the type 2. There's something behind. Then you go and make your prosthesis. You will notice expansion of the big bubble type 2 behind big bubble type 1. And then you will start now making your stromal dissection, and you will open the first brave slash. This is the first brave slash. Watch carefully. There is something here behind. Still, there is reflexes behind. What are these reflexes? I have opened already type 1 big bubble. So I will cut the stroma, and I will see what's going on behind. Cutting the stroma, you see these undulations in this membrane. This another big bubble behind it. You see another complete big bubble type 2 behind the first big bubble type 1. This is a very rare occasion. You can just puncture it. I have did in this case another brave slash, but you can just puncture it to decrease. You see this second brave slash, you will be having air out of the big bubble type 2, and you will be having an opening in Dua's layer and the smooth surface in this membrane and the rough surface is Dua layer, as if you are looking through a textbook of anatomy. So this shows the difference between type 1 and type 2 big bubbles. Type 1 in the left side with rough surface, type 2 on the right side with a very smooth surface. Dua's layer is very strong. It can withstand the pressure, as you see. This have done by mistake. You see how much pressure is applied over the Dua's layer, and still it resists rupture. So this is very characteristic of Dua's layer. You see? That's why this phenomena have encouraged me to do what I call it triple phaco DALK, doing phaco emulsification through this tough Dua's layer. We are doing big bubble type 1. You see, type 1, and then we do stromal dissection, and then we open the brave slash, and then we expose the Dua's layer, and then we'll start now doing phaco emulsification with its all techniques and with its mechanics and with the pressure gradients inside the anterior chamber. Start doing trypan blue staining, making capsulorhexis, injecting helon. You see, I am working through Dua's layer. I am fashioning now my phaco wounds. I make a counter pressure with the colibri not to have any perforation. And then we will do the operation as if we are working through normal full thickness cornea, making capsulorhexis and then making hydrodissection and rotation, nucleus rotation, as you see. And then we'll start doing phaco emulsification through the Dua's layer. And we can also make nucleus fracture chopping technique. Strangely enough, it will withstand all this pressure because it is a very tough layer. This video is just to tell you that Dua's layer is very tough. The aim of this video, of course, we may have some pros and cons of doing DALK with phaco or to do separate operation. A lot of debate around this issue, but I'm just showing this video to you to know that the Dua layer is very tough and it can withstand a lot of pressure. On the other hand, type 2 is very fragile. You see, it ruptures from slight stroma. Look to the arrow here. It ruptures very easily, and usually it makes a very large rupture because it's very fragile and has no strength like Dua's layer. We have what we call the burst big bubble. Sometimes when you are injecting air, don't use too much pressure during air injection. Otherwise, you may have this problem. You see, you have the bubble and then it will burst in the anterior chamber. You see? So this is what we call it the burst big bubble. And sometimes you may hear a sound, a clicking sound for this burst big bubble. Another example of burst bubble, you have in the bubble and then suddenly it will burst in the anterior chamber. Sometimes you may have what I call it a partial burst big bubble. You see, big bubble and it will burst, but partially. Still you have what we call it small bubble test positive. Another example of partial burst bubble, we have very minute burst in the big bubble, which allows some air to go out, but still the big bubble has enough air inside. That's why these small bubbles are displaced to the periphery of the anterior chamber. So the mechanism of this phenomena is we have a small tear in this membrane, or we may have a small undiagnosed hydrops which make leak of air during air bubble injection. I will go now through the step of paracentesis. Very important step. It should be vertical in orientation and it has be large enough, because this paracentesis, I will use it in the next steps, injecting air, injecting saline. So it should be large enough to be useful during my technique. So this big bubble type 1 and type 2, if you are going in horizontal orientation, like doing phaco, you will injure this membrane from inside. So you have to put your super blade vertically to have safe paracentesis. So this is how to do it. This is a big bubble type 1, making vertical paracentesis to avoid injury of this membrane from inside. I will show you now a very peculiar phenomena of what I call it expansion of the big bubble type 2. You see this big bubble type 2, you see when you do paracentesis, it will expand, you see? It will expand to the periphery, you see? So you have to be very careful during the paracentesis, otherwise you may injure by yourself. Look to the second example, which has a tremendous expansion. You see, look to this example, big bubble type 2. Look to this arrow. You see, it expands very much. So you have to be very careful during paracentesis, otherwise you may injure the big bubble by yourself. The sixth step is the lamellar dissection. You go doing stroma dissection by crescent knife. It's a very easy step. The aim of this step is to make debulking of the stroma to open safely the big bubble after this. So sometimes we may find a lot of emphysema, so you may draw a gentian violet marking around the terrifying edge to have a safe dissection. The second trick situation I will speak about is what we call the premature unintentional roof opening. As you know, when we make stroma dissection, we go and open the roof, but what we call the brave slash. So this is intentional opening in the proper time. Sometimes it occurs prematurely or unintentionally, like this example. It may occur in the beginning of the section, or it may occur in the middle or in the last minute. So you are to start the section, you're getting opening of the roof prematurely. We don't want to open the roof now, or what I call it the unintentional. You go and inject viscoelastic again to reform the big bubble space and continue your dissection. Sometimes this premature opening occurs in the middle of the way. Look here, we are in the middle of the way, and then suddenly it opened the big bubble roof. So you have to recognize, you have to stop, change your plans. No way, you don't have the chance to do brave slash. You have to change your strategy and go and make cutting of the stromal flaps as you see, because if you go and do the brave slash, you will damage this membrane. Sometimes it will occur in the very last moment of the section. Watch carefully these small bubbles which are displaced in the periphery of the anterior chamber, because we still have the big bubble space here. Look carefully, these small bubbles will move centrally now. Look, it moved centrally. Look, because you have opened the roof in the very last point. So you have to stop and you have to look for this tiny opening and change your policy. Again, why it is crucial to diagnose such situation, because not to damage this membrane, and you are not allowed to do brave slash if you have a premature roof opening. The fourth group of tips is how to do or how to open safely the big bubble roof. So this is what I mean by the big bubble roof. This is the roof. We want to open the roof and to get out the big bubble space. So the aim of this step is to make safe opening, which means that we don't want to injure this membrane, and it should be large enough, because if you do a small opening, you will be stuck in removing the remaining stroma. So this is an example of a good brave slash, very large. You can use it for the next step. Another, a very useful tip is we can put a cohesive viscoelastic over the stroma. This will make very safe brave slash. Another example, putting cohesive viscoelastic over stroma, you can make the brave slash safely, and you can withdraw your hand before you damage this membrane. So there is a problem, what we call it tiny big bubble roof. You will be able to make a safe big bubble roof opening, but this opening is tiny. As you see here, this is a big bubble type 1. You make stromal dissection and you go to the brave slash. It's okay, not net. It's open now. But when you look to this opening, it is very tiny. You want to enlarge it. It's impossible to enlarge it because you have this membrane just touching stroma. So you have to increase magnification. Look carefully for this tiny opening, because you want to introduce your scissors and you want to cut the remaining stroma. So you have to look carefully. You see, I am spending a lot of time looking for these tiny perforation until with some patients, I find this perforation, and using a super blade, I can cut over it, you see, until I have the large opening, and then I continue my operation safely, as you see. So the ideal big bubble roof opening is to have a safe and large, you see, large. This is a very large, which allow you to enter with your scissors to continue cutting the stroma. This is another example of the large big bubble roof opening. You see, very large opening, which allows you to enter with your scissors, and it is not tiny anymore. So these are examples of the brave slash. As I always say, don't be afraid. The distance between the stroma, the roof, and floor is very large. And if you are hesitant and ended with a small, tiny opening, you will be stuck in removing the remaining stroma. The second step after this is cruciate incision and stromal cutting. You may either inject the viscoelastic in the big bubble space and start cutting the stroma, or I prefer now using the dry technique. There is no need to use viscoelastic anymore. Just go by your blunt tip scissor and using your right and left corneal scissors to cut the stroma and to remove the remaining stromal flaps, as you see. As I always say, look carefully how neat the wound is. This is a wound made by simple instruments, not by femtolaser. So these neat DALK wounds do not differ too much from the amazing femtolaser wounds. It only requires some surgical skills and good quality instruments. The ninth step is descent membrane stripping. It's very easy. After telefination, make staining of descent membrane and start rubbing at a certain point until you have it. You have the edge, and then catch the edge by McPherson or by tying forceps. Or another example, sometimes it comes out very easily by peeling, and sometimes it's adherent according to the patient's age, for example. Another example, very easy stripping of descent membrane. A very important step in this important point is that don't waste this chance. This is your chance to learn half the mech. While you are stripping descent membrane, you can do it as if you are making a DMEC operation. So this is your chance to learn half of the DMEC operation during your DALK learning course. So as I always say, during your DALK cases, don't forget to practice the DMEC preparation. The last step is graft suturing. It has no difference between penetrating keratoplasty and the DALK in suturing, but be careful of inadvertent descent membrane perforation during suturing. As you see, finally, DALK has lots of tricks, but if you follow these steps and advices, I am sure you will be able to execute the perfect big bubble DALK. And these are my contacts, whether the email, Facebook page, YouTube channel, WhatsApp number. For any assistant who want to start DALK, I will be with you during your learning care. Once more, I would like to thank Dr. Rajesh Fogla and Dr. Sharon for this kind invitation. And I'm always honored to be part of the teaching program of the Indian Corneal Society. Thank you very much.
Thank you very much, Dr. Katamish. I really, I feel like applauding for that such beautiful step-by-step videos. And I'm sure it has been extremely helpful to everyone who has joined today. I'm sure, no matter how many times we do this surgery, there's so many nuances and tips that we learn. So there are a few questions for you, if you're not too tired.
No, my pleasure.
Yes. Dr. Saili, would you like to ask your question?
Yeah. Hello, everyone. So what is the reason behind collapsing bubble? Is it positive posterior thrust, vitreous pressure? What is the reason?
Of course, I have no study on this phenomena, but my opinion is the reason for this collapse in big bubble is the nature of the cornea itself. I have noticed this phenomena in some cases of keratoglobus with very weak stroma. So I think since you are introducing your cannula in a very weak stroma, the tunnel will be somewhat wide, so it will leak air. This one point. The second point, I am always injecting very, very deep. And as you know, the deep stroma is not as compact as the anterior stroma. So I think this may be another cause of having such phenomena, the collapse in big bubble. But of course, I don't have studies on this big collapse in big bubble. But these are my two explanations. But it is not common, as you see in my presentation. I have presented about few cases, but it is a very rare phenomena. And since you have aware of it, you will be able to how to manage it. I think Dr. Rajesh has some publications or some comments on this collapsing big bubble. If we can hear his opinion, to be great also.
No, I think you made the right point. It's basically that sometimes as you withdraw the cannula, because the big bubble is very tense, the stroma and the cannula, they get kind of compressed by the large presence of the big bubble. So when you're pulling out your cannula, the tip of the cannula may go bend down a little bit, and then kind of it breaks the stroma. It creates a communication between the big bubble and the track, so you get leakage. And this will be more common if you advance your cannula right to the center of the cornea, because then there is a long distance that you need to withdraw the cannula. And while withdrawing, if your tip of the cannula bends down, then it can create that, a track to leak air. And this typically happens if your cornea is very thin, or the residual stroma between the cannula and the type 1 bubble, as Dr. Tarek Katamish mentioned, that stroma is hardly a very thin layer, so it's possible for the air to leak out.
Yes, exactly.
So
I think.
The paper that we published, we said that before you remove your cannula, you should do a paracentesis to release the aqueous so the posterior pressure is minimized, and rotate the globe downwards a little bit when you're pulling your cannula out. So that what happens is, otherwise, sometimes with a patient with a very prominent brow, you tend to bend the cannula to bring it out, So
Yes.
in that process, the tip goes down. Whereas if you rotate the globe down, then you can straight away pull the cannula out without having to make an effort to push the tip down.
But you agree with me, Rajesh, that it is a rare, it's a rare occasion, very rare.
And you don't see it very commonly. And especially after I started putting my cannula paracentrally rather than towards the center, I kind of see it very rarely.
Yes, exactly.
There was a question, from Dr. Jitendra. Dr. Jitendra, would you like to ask a question?
Yes. Good evening, sir.
Good evening.
Sir, my question is like, do you really remove sutures after doing DALK, or if so, what is the exact timing to do that?
I'm sorry, I have some disconnection. Can I have the question, please? Or Dr. Sharon explain to me the question.
What is the timing of suture removal?
The time of suture removal?
Yes.
Yes.
Yes. I'm usually, I don't remove sutures before 1 year. If everything is okay, I don't remove sutures before 1 year. And after 1 year, I look to the suture line. If it is, the scar is white, I can remove it safely. But if the scar is still not clear or translucent, I can wait for another 6 months. And of course, this in the situation that you have a straightforward case and don't have any problem from sutures. But if you have problems from sutures, for example, exposed suture, loose suture, you have to remove it immediately whenever you have it, because you may have some vascularization and some sort of reaction and some sort of penetration in the interface and lipid deposition. So whenever you have any loose suture, you have to remove it. But for the straightforward sutures, which are well in their place, I should wait for at least 1 year.
All right, sir. Thank you.
So one question that I think may be rising in a lot of their minds is that why do you prefer to do the bubble and then do the debulking of the stroma? Why do you find that easier, sir?
Yes, I know that some surgeons do the reverse, doing even paracentesis first and then doing the mirror dissection. But for myself, I want to do the introduction of the cannula in a well-formed group. I have tried to do the paracentesis first and then to introduce my cannula. I found the mechanics are not that good, and I found wrinkles in the cornea while introducing my cannula. So I prefer to do my injection on a version globe, which is still not open. And I know that Dr. Rajesh has a different opinion. He is doing lamellar dissection first because he don't want the distant membrane to be touching the iris for a long time. So he want to make injection and making the brave slash immediately. And some surgeons also prefer to do lamellar dissection first because they are claiming that you are getting deeper. But in my technique, I have shown that I can go as very, very deep as I want without making this lamellar dissection. So I prefer to do it as I have described.
Yeah, I think it's beautifully demonstrated. So for all our doctors here, you have seen, both sides, how to manage from both sides, whether you do the lamellar dissection first or the bubble or directly the bubble. But just remember what is important to get the bubble in each of those.
Another point, sometimes you may have a very thin cornea, and if you are doing the lamellar dissection first, you may perforate.
Absolutely. Yes,
so this may be a problem from the start. So most of the cases are keratoconus and you have a very thin center, and I don't want to have any accidental perforation before to start the operation.
Yes. I think Dr. Sonal has a question. Dr. Sonal, are you here? So,
am I audible now?
Yeah, now you're audible.
Yeah.
Go ahead.
Sir, do you prefer replacing the suture if you remove before 1 year, or you just keep it as it is?
If I have a loose suture and the wound edges are approximated quite good, I just remove the suture and don't take any other suture, because the already loose suture has nothing to do in keeping the wound apart. But if I have loose suture and I have some gaping of the wound, I will remove the suture and take another one after making freshening of the edge of the wound. You should have freshening of the wound edges before taking a suture, because if you are taking a suture while the wounds are approximated, it will not has its effect. You have to refresh your wound at the site of the suture and take another suture. So if you have loose suture with no wound gape, I just remove it. But if you have a loose suture with some gaping, I will remove it and take another one.
Okay, sir. Thank you.
Thank you.
Dr. Siddharth, you can go ahead. Anyone who has a question, please go ahead and ask. Not a problem.
Sir, is pentacam thickness reliable always at 8 millimeters?
Excuse me, can you repeat the question, please?
Sir, is pentacam thickness at 8 millimeters reliable to judge or refine depth? And
yes, in my hands, it's very reliable. I usually ask the technician to have a wide view. I have the corneal thickness in a one view, magnified view, and I go to the 8 millimeter, for example, diameter, and choose according to the light scoring. I'll choose the thinnest location, and then having a safety margin of taking 80% of this thinnest location. This is the usual way of doing the job. But for myself, I have done a lot of DALKs and I have done a lot of LASIKs, and I can myself on the slit lamp go to the mid periphery of the cornea all around, and I can judge for this patient. I can use, for example, 8 quarter turns. For this patient, I can use only 5. For this patient, I can use 4. This from experience. But depending on the Pentacam map is very, very accurate, at least in my hands.
Okay.
And of course, you can use, if you have an intraoperative pachymetry, ultrasound pachymetry, you can use it directly in the operation room at the 8 millimeter diameter. You can measure different sites by ultrasound pachymetry and take the least amount and just take 80% from this number.
Okay.
So one more question, sir, for you or for Dr. Fogla. So when we're doing the bubble injection, if the air is escaping out of the track before achieving the bubble at all, the air is escaping out of the track. I had seen a video of a surgeon who suggested using a thicker cannula, a broader gauge cannula, to then, go into the track. How would you approach? Would you go in the same track, or should we take a different track? How would we tackle that?
I think prophylaxis is better than cure, as we always say. I have a good tip for such a situation. I'm usually doing my tunnel by the spatula,
Yes.
blunt spatula, the same gauge as injecting cannula. So I go by my blunt spatula, for example, 4 millimeter inside the cornea, and then withdraw it, and then go with my blunt cannula for 5 millimeter. I have 1 millimeter
Beyond.
in advance to have the stroma very tight. Yes. Around the tip of the injecting cannula to avoid this leaking track. But if I have faced this situation, I think I'd rather prefer to change the site, not to use a thicker cannula, yes, which is not available. I have only one blunt cannula for injection. So if I have such leaking track, I rather change the site.
Yes. Yes, so that's a very, very important point for all our doctors here. One is that if you're seeing, so understanding the air dynamics in DALK is very, very important. So if you see the air leaking or the air is coming backwards, air is tracking around the cornea, that's not a good sign. And it would rather, you could stop and start from a different site. You don't keep injecting because you don't want that total emphysema as far as possible. You want to get, those beautiful bubbles which Dr. Katamish and Dr. Fogla have shown. So that way. Any more questions from our trainees? So another important point for discussion, in your experience, the dissection or even the bubble, how different, or is there any difference in the keratoconus or PMD patients? Do you find that there's any difference in the way you dissect or the resistance you feel, anything like that?
Do you mean the difference between keratoconus and
pellucid?
Pellucid
yeah, keratoglobus or pellucid, any of them. Is there any difference in the resistance you feel?
I have mentioned in my talk or on answering my questions that in the keratoglobus, you have a very, very stroma is very, very fragile stroma. So when you are, and I have already shown one of my collapsing big bubble, which one was a transparent big bubble. This was a case of keratoglobus. I find that dissection is very easy and very easy, yes, very easy. But unfortunately, not unfortunately, we don't have a lot of keratoglobus or pellucid in our country. Our cases are mostly keratoconus, straightforward keratoconus.
Yeah, I think similar here as well. Actually.
Madam, one question.
Yes, please. Go ahead, Dr. Siddharth.
Sir, actually in scar cases, where the scar is mid-stromal or deep stromal and large. So can you guide us? How do you preoperatively assess, apart from OCT or whatever, how do you assess in such cases? Like the depth of the scar and whether to go for real DALK or whether it is aborting the decimates like that. Such cases where you do manual DALK, how do you assess whether it will be successful or you should go for a PKP?
I think what is important in this situation is the involvement of descent membrane. So if I have the scar deep enough and involving descent membrane, and so injecting air in this situation will not be very valuable, and I am supposed to have mixed big bubble type 2, which may jeopardize my big bubble DALK. So I decide in such situations to do manual dissection directly. And if to do or not to do PKB in such cases, the clue in these cases that the corneal thickness, if I have corneal opacity and I have the cornea still compact of normal thickness, this means that I still having a healthy endothelium and I can do that. But if I have corneal scarring and I have some sort of corneal edema or thickened cornea, this means that the descent membrane or the endothelial cells are not healthy, and this will give me a clue that I have to do peritonic keratoplasty in such cases.
Thank you, sir.
So I'm sure a lot of people will want to ask this. So what are your tips if they do have a perforation while, like, towards the later stage of the surgery, even during suturing or, towards the posterior layer dissection? What are your tips for managing it and continuing as a DALK?
If you are asking of perforations during suturing, this usually a very benign perforation. Yes. And my advice is when I have a perforation through one suture, I usually take off this suture and I take another one beside it, because when I leave the suture in place, it may enlarge the perforation. And I leave, of course, air at the end of the operation, and I will try to observe the patient in the first few hours to guard against pupillary block, and I keep the patient dilated. And but I don't think I will do an inferior PI in such situation, because the instance of big double anterior chamber in this perforation, I think, is very, very low, in contrast to the perforations which occur during the operation itself. Sometimes we have large perforations which has a very high incidence of double anterior chamber. But these minute, tiny perforations during suturing, in most of the cases, they are more or less benign, but we have to put some air and to dilate the pupil.
Okay. Great. I think, thank you very much, sir. It's been a great session, and you've very patiently taken all our questions and cleared the doubts. And of course, I don't think, after your series of videos and the presentation, I don't think there were too many doubts in any case. And we look forward to meeting you. And I'm sure by then we'll have more questions and, to ask you in person. So thank you very much, sir. And Dr. Fogla, sir, also, even though he's traveling to join us. On behalf of everyone here, thank you.
It's a pleasure to listen to your presentation, although some of them I have heard recently in Thailand as well, but it's always a pleasure to watch your videos. And I must thank you for accepting our invitation at a very short notice, taking almost an hour's time to present and interact with our Cornea Society members and people who are taking the course. And it's nice. I think such a golden opportunity people should not miss, because anybody else will so passionately teach about the big bubble DALK surgery. And thank you once again. And if it's okay with you, this session of Zoom will be recorded. Yes, we can then among our other Cornea Society members. So for people who may have missed out today's session, we'll be able to, go over the presentation once again. We'll send you a link as well, so that if you want to share it with, others, you can do that, because it's such a wonderful presentation, and I think people should benefit from this.
Thank you very much, Rajesh, for this comment, and it's always my pleasure to be to share with you such very comprehensive courses. And I have mentioned in my talk that some of my tips I have learned from you. So you are not just a friend, you are a mentor to most of the corneal surgeons all over the world.
Because we share all our work, we learn from each other. Every time we watch each other's videos, I'm sure we pick up few points that go a long way to manage and provide better care for our patients.
Exactly. And I would like to thank, of course, Dr. Sharon for her patience with me and updating me with the emails and links for this meeting.
Very brilliant DALK surgeon. I'm sure I'll tell her to share with you some of her surgical videos. In one of the recent meetings, she did a live DALK surgery as well. So next time, maybe you are in India, you should visit their institute. It's a very big eye.
Of course. My pleasure, of course.
Thank you, Fogla sir.
Yes.
Okay, so thank you very much, everyone. And with that, we will sign off.
Okay.
And see you at Karakon next week.
See you at Karakon, yes. And good night, everyone.
Good night.
Good night.